Leukemia classification, understanding acute and chronic blood cell malignancies. Leukemia classification systems help clinicians diagnose and treat blood cancers effectively. Understanding the distinctions between acute and chronic forms, along with myeloid and lymphoid subtypes, is essential for determining prognosis and treatment strategies. Introduction to leukemia classification. Leukemia represents a diverse group of malignancies affecting blood-forming cells within the bone marrow. The classification of leukemias serves as a fundamental framework that guides clinical decision-making, predicts disease behavior, and determines appropriate therapeutic interventions. Medical professionals rely on systematic classification schemes to distinguish between different leukemia subtypes, each with distinct biological characteristics, disease progression patterns, and treatment responses. This article explores the major classification systems used in modern oncology and the clinical significance of understanding these distinctions. The fundamental division: acute versus chronic leukemias. The most basic classification divides leukemias into two broad categories based on disease progression speed and cellular maturation patterns. Acute leukemias are characterized by rapid proliferation of immature blood cells, resulting in an aggressive clinical course that demands immediate intervention. These malignancies typically manifest with symptom onset occurring over days or weeks, and without treatment, they can prove fatal within a remarkably short timeframe. Chronic leukemias, by contrast, develop gradually and often remain relatively stable during initial phases, allowing patients more time between diagnosis and the need for intensive treatment initiation. Key points: acute leukemias progress rapidly with predominantly immature blast cells in circulation. Chronic leukemias evolve slowly with a higher proportion of mature cells mixed with abnormal populations. Acute forms typically present with severe systemic symptoms requiring urgent medical attention. Chronic variants may be discovered incidentally during routine laboratory work. Cellular lineage classification, myeloid and lymphoid origins. Beyond the temporal distinction, leukemias are further classified according to which blood cell lineage becomes malignant. The myeloid pathway produces granulocytes, monocytes, and other innate immune components, while the lymphoid pathway generates lymphocytes responsible for specific immunity. When transformation occurs within the myeloid compartment, the resulting condition involves accumulation of abnormal myeloid cells that progressively displace normal hematopoietic elements. These aberrant cells interfere with the bone marrow's capacity to produce adequate quantities of functional blood cells, leading to secondary effects including anemia, thrombocytopenia, and immunosuppression. Lymphoid leukemias arise from malignant transformation of lymphocyte precursor cells or mature lymphocytes. The distinction between myeloid and lymphoid origins carries significant prognostic implications and influences therapy selection, as treatment protocols have been specifically developed and optimized for each pathway. Understanding the cellular lineage involved in each individual case enables oncologists to predict which therapies will demonstrate the greatest efficacy while minimizing unnecessary exposure to toxic agents that would be ineffective for specific disease types. Acute myeloid leukemia, characteristics and significance. Acute myeloid leukemia, AML, represents one of the most common acute leukemias in adults and exemplifies the aggressive nature of acute myeloid malignancies. This disease involves uncontrolled multiplication of immature myeloid cells that accumulate rapidly within the bone marrow and peripheral blood, crowding out normal hematopoietic elements. The expansion of these abnormal cells impairs normal blood production, resulting in multiple clinical consequences that patients experience as constitutional symptoms and organ dysfunction. Patients with newly diagnosed AML frequently present with symptoms reflecting inadequate normal blood cell production. Fatigue and dyspnea result from anemia caused by decreased red blood cell production. Easy bruising and spontaneous bleeding occur due to thrombocytopenia limiting platelet availability. Recurrent infections emerge from neutropenia and functional impairment of remaining myeloid cells. In addition to these hematologic complications, AML can disseminate beyond the bone marrow and blood, occasionally involving the central nervous system, integument, and oral tissues. The rapidly progressive nature of untreated AML necessitates prompt recognition and initiation of aggressive chemotherapy to achieve disease remission before critical organ dysfunction develops. Morphologic and cytochemical classification systems. Historically, leukemia classification relied heavily on microscopic examination of bone marrow and blood cells using various staining techniques and morphologic criteria. Pathologists assessed the size, shape, and staining characteristics of abnormal cells to categorize leukemias into specific subtypes. Cytochemical studies, including myeloperoxidase staining, Sudan black, and periodic acid Schiff reactions, helped distinguish myeloid from lymphoid differentiation and identified specific maturation pathways. These techniques provided valuable information about the degree of cellular differentiation and helped predict response to certain therapeutic agents. Key points: myeloperoxidase positivity indicates myeloid differentiation and helps identify acute myeloid leukemias. Morphologic classification systems assess blast percentage and degree of cellular differentiation. Historic FAB, French-American-British, classification used morphology and cytochemistry to define subtypes. Cytochemical patterns assist in distinguishing monocytic from granulocytic differentiation. Immunophenotypic classification approaches. Modern leukemia classification increasingly incorporates immunophenotypic analysis using flow cytometry, which detects characteristic patterns of cell surface and intracellular markers on leukemic blasts. This methodology identifies specific clusters of differentiation, CD, antigens that define lineage assignment and maturation stage. Immunophenotyping provides superior resolution compared to morphology alone, enabling recognition of rare subtypes and identification of unusual phenotypic features that may influence prognosis or treatment selection. Additionally, flow cytometry can identify the presence of abnormal precursor populations at very low levels, which proves valuable for monitoring minimal residual disease during treatment and following completion of therapy. The immunophenotypic profile serves multiple clinical functions beyond simple diagnostic classification. Certain marker combinations associate with specific genetic abnormalities that carry prognostic significance and predict treatment response. For example, particular immunophenotypic patterns may indicate presence of underlying chromosomal translocations known to respond favorably to targeted therapy. Flow cytometry results guide physicians toward appropriate diagnostic and prognostic investigations while simultaneously enabling earlier detection of disease recurrence through sensitive monitoring of leukemic cell populations in follow-up samples. Cytogenetic and molecular classification framework. Contemporary leukemia classification systems increasingly emphasize cytogenetic and molecular genetic findings as primary organizing principles. Chromosomal abnormalities and specific gene mutations carry profound implications for disease behavior, prognosis, and therapeutic response. Recurrent cytogenetic abnormalities have been identified in leukemias across the morphologic spectrum, and their presence significantly influences treatment recommendations and expected clinical outcomes. Molecular techniques including fluorescence in situ hybridization, FISH, karyotyping, and next-generation sequencing detect these critical genetic changes that define disease subtypes. Key points: balanced translocations create fusion genes that drive leukemic transformation and may respond to specific targeted agents. Complex karyotypes with multiple abnormalities generally carry worse prognosis and predict shorter survival. TP53 mutations indicate aggressive disease biology and reduced sensitivity to conventional chemotherapy. FLT3, NPM1, and SEPA mutations help stratify AML into prognostic risk categories. WHO classification system integration. The World Health Organization classification integrates morphologic, immunophenotypic, cytogenetic, and molecular data into a unified diagnostic framework that has become the standard for leukemia classification in clinical practice. This comprehensive approach recognizes that no single parameter adequately captures the biological diversity of leukemias. Instead, multiple data elements combine to define specific disease entities with distinct clinical implications. The WHO system includes separate categories for acute leukemias, chronic myeloproliferative neoplasms, myelodysplastic syndromes, and other hematologic malignancies, with further subcategorization based on the genetic and molecular features identified during diagnostic workup. Clinical implications of classification. Accurate leukemia classification directly impacts clinical management decisions and patient outcomes. The specific leukemia subtype influences selection of induction chemotherapy regimens, determines whether targeted molecular therapies should be incorporated, and predicts the likelihood of achieving complete remission with standard protocols. Classification also guides decisions regarding consolidation therapy intensity, the appropriateness of hematopoietic stem cell transplantation, and post-remission surveillance strategies. Patients with unfavorable cytogenetic features or adverse molecular markers may benefit from more intensive approaches or novel therapeutic agents, while those with favorable prognostic features may achieve cure with less toxic conventional chemotherapy. Emerging refinements in classification. Leukemia classification continues to evolve as technological advances enable more precise characterization of disease biology. Next-generation sequencing now identifies previously unrecognized mutations affecting prognosis and treatment response, while sophisticated immunophenotyping can detect rare disease populations with unique therapeutic vulnerabilities. Gene expression profiling and other advanced molecular techniques are beginning to refine prognostic stratification beyond current cytogenetic and mutation-based approaches. As these technologies become more accessible and affordable, classification systems will likely incorporate additional molecular parameters that further personalize prognostic assessment and treatment selection. Conclusion. Leukemia classification represents a cornerstone of modern hematologic oncology that enables precise diagnosis, accurate prognosis prediction, and treatment planning based on disease biology rather than empiric approaches. The integration of morphologic, immunophenotypic, cytogenetic, and molecular data provides comprehensive characterization of individual leukemias, guiding physicians toward optimal therapeutic strategies. As classification systems continue to evolve with technological advances, they promise increasingly precise risk stratification and identification of therapeutic targets, ultimately improving outcomes for patients with these aggressive blood malignancies. Understanding leukemia classification enables healthcare providers to communicate effectively with patients about disease characteristics and expected treatment responses while facilitating access to appropriate clinical trials and novel therapeutic approaches. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.